All right, we've had a great morning, exciting photo, and I know you all enjoyed it. We're excited to have a friend and a colleague, Marc Bonaca, come up here. He's a professor of medicine, directs vascular research, and is director of CPC. I can't think of anybody who's thinking through the metabolic interface, but I'll call it all the science around what we're trying to do for our patients. So excited to have Marc come up here and give us a talk here as he thinks and helps us think about the metabolic interface and where the science is going. Thanks, Marc.
All right, well, thanks everyone. Thanks to Mike and Isabel and the whole Vascular Cures team for inviting me to be part of this outstanding session today. So I'm going to talk a little bit about peripheral artery disease and some of the evolution of medical therapy and now how we think about interfacing with cardiometabolic disease and metabolic therapies. I'll start with a slide that won't be a surprise to any of you, and that's the rate of change of vascular disease or peripheral artery disease. By decade, it's increasing by about 20 to 25%, a really growing pandemic. And, Manesh is going to be president of the AHA. We're going to be talking a lot, at AHA about heart failure and atrial fibrillation. These are things that get a lot of attention. But in the United States, there are about twice as many individuals that suffer from peripheral artery disease and heart failure or AFib, yet it's been largely, neglected when it comes to pharmacotherapies until the recent era. Now, we talk about who has PAD. There have been a number of screening studies, but I think the bottom row here kind of summarizes it. This is a disease of aging, smoking, and diabetes, but it has shifted. That the phenotype of the smoker with large vessel athero has largely now shifted or is increasingly shifting to the patient with diabetes, small vessel disease, and microvascular disease. And in fact, we think a lot about heart failure as a complication of diabetes. The SGLT2 inhibitors were sort of a first signal of that, and now broadly for heart failure. But it's actually peripheral artery disease that's the most frequent first manifestation of cardiovascular disease in patients with diabetes. And I'm going to talk more about that, but that's because it's not just a macrovascular complication, it's also a microvascular complication. It's also the canary in the coal mine. If you think about it, if we could catch people the left side of this slide, we could prevent a lot of the things that happen on the right side. So you've heard about the cardio-kidney metabolic axis. This is really how peripheral vascular disease, peripheral artery disease, as well as coronary disease and stroke are evolving because we have this pandemic of cardiometabolic disease. And this heat map on the right, this is Phil Goodney's work through the AHA PAD Collaborative, where you can go to the website there and you can look up in your own zip code and look by demographic and everything else where amputations are happening. And it's not, as you saw earlier today, it's not distributed equally across the country, and there's clearly issues here aligned with socioeconomic factors, justice, and access to healthcare. So when we think about the metabolic sort of component of this, it's helpful to sort of rewind a little bit and think of where we were. This is about 2 decades of development of medical therapies in PAD up until I graduated from my fellowship in 2010. And this was the PAD guidelines in 2005, Alan Hirsch wrote, and then 2016. And along the top, it was ATT said aspirin reduces MACE, Capri, clopidogrel reduces MACE, maybe it's a little better than aspirin. Neither of them do anything for the limbs. As monotherapy, HOPE ACE inhibitors are good for patients with cardiovascular disease for reducing MACE, and HPS was statins. WAVE and Charisma showed us that more potent antithrombotic strategies are complex in PAD. And then in the middle of the slide, several studies trying to look at pharmacologic adjuncts to revascularization to improve risk. They were largely unsuccessful. One drug approved that actually works for symptoms in PAD, and that was in 1999. This is, wanted to highlight this slide. These are some of my key mentors. Josh is in the back, and Dr. Bromwald, who Dr. Patel mentioned earlier, recently passed away. These are some of my mentors I was fortunate enough to work with. And I think I raise this because we're coming together as a group of people that are unified by a desire to help patients with vascular disease. And we have to look to the person next to you in terms of how they can help you and support you. I think we can do a lot together. For me, it was this amazing sort of mix of vascular expertise and clinical trial expertise. And Mike, you'd left before I got into my training, but we interacted as well. And you and Marc Krieger wrote this paper on acute limb ischemia. And this was this, horrific event as a cardiology fellow. I never saw it, but as a vascular medicine fellow, when I was rotating with our vascular surgeons, we actually saw a lot of it, and it was bad. And that sort of raised the question of how do we improve outcomes for patients with PAD? And we had a chance to investigate this in a clinical trial. This was a trial we did at TIMI looking at a thrombin receptor antagonist. So, what's the role of thrombin added to antiplatelet therapy? And this was a positive trial, led to approval of the drug. It's not used much because of the bleeding risk, but it was a positive trial. And we asked the question of, could you modify a limb outcome? And so we prospectively adjudicated acute limb ischemia, this large vessel thrombotic phenomenon. And lo and behold, not only was it modifiable, but it was frequent, a bad outcome, and highly modifiable. And that really led to this notion of thrombin as a bad actor for large vessel athero. Then came the era, and Manesh and others led a lot of work in this space of dual pathway inhibition. So maybe instead of a thrombin receptor antagonist, we can interrupt thrombin generation, move higher up on the right side in the coagulation cascade, combine that with an antiplatelet, and improve outcomes. So Will Hyatt, Manesh, myself, and others, embarked on this trial called Voyager. I raised this because the primary endpoint here was one of the first to include as a registration trial limb outcomes, but they were very specific limb outcomes. So acute limb ischemia is large vessel artery-to-artery embolism and major amputation of a vascular etiology. That was very purposeful because a lot of amputations in this space aren't modifiable with antithrombotics, right? Minor amputations. This was a sister trial, was Compass. This was a largely stable population of CAD or polyvascular disease, and a positive trial. Sonia Anand's work in the upper right, really elegant, adjudicating limb outcomes and showing a benefit there, including major amputation. But note it's major amputation. Look how few there are, because this is a highly selected endpoint based on what's modifiable with antithrombotic therapy. So Voyager was positive. It was the first trial to show that you could modify irreversible harm events of the heart, limb, and brain in patients with PAD after revascularization. There was bleeding risk, but overall a favorable benefit risk. And that led to the first approval of a drug ever for preventing a limb outcome. So now it's not just about heart attack and stroke, but it's about acute limb ischemia, major amputation, and opening a new therapeutic pathway for approval. So Marc Krieger, who had been a mentor at the Brigham and still is, and Will Hyatt there, he made me climb a mountain even when he had stage 4 lung cancer, and he had to wait for me. I couldn't keep up with him anyway. And many of you knew him and loved him. And Marc wrote this really nice editorial to the paper, Bon Voyageur for PAD. But there was a problem, and we're going to get to that in a moment. At the same time, other mechanisms, so cholesterol lowering, right? This is PCSK9 inhibitors, the Fourier trial. Lowering LDL with a PCSK9 inhibitor reduces major adverse limb events. Again, large vessel athero, so major amputations, acute limb ischemia. Why? Because it's artery-to-artery embolism. You're stabilizing plaque in the aortoiliacs. They don't rupture. You don't get that. Same for other drugs. So ezetimibe on the left, bempedoic acid on the right. They also reduce limb outcomes, including revascularization and symptoms. So, progress in terms of medical therapy for specific types of events. But there's a problem. And one of the problems is this. This is sort of what I call the inverse pyramid of drug development, which is, we've been very focused on MACE, and that's bad. Don't get me wrong. Heart attacks and strokes are very bad, but the rate in a stable PAD population is probably about 4% per year. Male or limb outcomes, as I showed you in Voyager, are more frequent, and some of them are devastating, but about 10% per year. Every patient with symptomatic PAD wakes up every single day, limited, unable to do activities of daily living, walk to the mailbox, play with their kids, and there was one drug that was shown efficacious and approved over the last 25 years. And so there's a real gap in terms of the need and the development of novel therapies. So that's one problem. Another problem is this, best CLI. So Mike and Josh was on the medical monitoring committee. Manesh is running a registry. There's a bunch of people involved in this landmark trial, which showed that bypass surgery with a good vein is better than endo for preserving limbs and preventing major adverse limb events in patients with CLTI. Great trial, right? Well, look at the bottom right corner. 60% of people were dead at the end of the trial. So if we save the leg but we lose the life, are we really accomplishing what we need to as a group? So around this time, there was the SFRN, and we have one of the members of our advisory board there, and then we had Josh Beckman was leading one of these, and we were trying to figure out a problem, and that's in all the trials I just showed you. There's a whole bunch of stuff that happens to limbs that we weren't talking about, and that was diabetic foot ulcers, infections, minor amputations, a lot of bad things. And we looked in a trial called SAVOR with a DPP-4 inhibitor, and it had no effect. And this was a major burden. And so, Phil at the far right, Goodney did the heat map that I showed you earlier, and Marc Feinberg, Mark Sabatine, Mark Krieger, and so on. And so we did, I'm just going to show you a couple of things. But one was in Euclid. So this is a trial that Manesh led, biggest stable PAD trial I think ever done. And we asked a simple question of, if we want to prevent amputations in diabetes, what do we need to do? Well, if you look at the two pie charts on the left, whether it's major amputation or minor on the bottom, the blue, the true ischemic amputations, are actually a minority of amputations. They're all either driven primarily or in combination with infection. So there's a real infectious overlay, which is different than patients without diabetes. And so that's a major issue. How do you modify that with lipid lowering? How do you modify that with antithrombotics? So we looked in the DECLARE trial, that's on the left here. So in DECLARE, we had to adjudicate everything in the limbs because there was a concern about harm with SGLT2 inhibitors. The FDA requested that we do this. And what you can see in a patient population with diabetes, that if you combine large conduit artery PAD with diabetes, it's really bad for everything in the legs. It's bad for infections. It's bad for any adverse limb event, much higher rates, not just acute limb ischemia. And again, just as we saw in Euclid, the dominant driver is actually infection and microvascular disease. Now, Josh led this really beautiful study on the right, and he was way ahead of the curve here when he said, microvascular disease is an independent predictor of amputation. And when you add that with large vessel conduit artery disease in the far right, in that bright red bar, it's a really malignant phenotype for amputation. So we have a problem. And really what that gets to is the different biology for PAD. And that's why the metabolic lens is so important. We have extrapolated for a long time from coronary events, where it's largely a large vessel phenomena, whether it's plaque rupture for acute coronary syndrome, whether it's functional limitation, you have angina. There is microvascular disease, but the typical historic construct has been large vessel stenosis, and then tissue loss is, you have an MI and you lose tissue. But in PAD, it's just a lot more complicated, and everyone knows that here. When you see this in your clinic, when patients come in with muscle atrophy, hair loss over the leg, ulceration, microvascular disease, it's a much more complex disease state. And so I don't have the fancy pictures that Radhika showed and Kathy showed. This is my very simplistic view of this. But on the far right, we made a lot of progress where we can lower lipids and thrombosis and reduce macrovascular outcomes. And that's great for heart attack and stroke. But when you look at, as you move to the left, PAD, much more similar to kidney disease, as we heard about from Kathy, this is an issue of microvascular disease, and where there are other factors, inflammation, blood pressure, glycemic control, other factors that are at play here. And we can't really move the needle for PAD unless we address the left side of the slide. And this has been known for a long time in diabetes. I learned from Josh, Darren McGuire, and others that, in the diabetes world, there's, microvascular complications like retinopathy, neuropathy, nephropathy, and then there's the macrovascular ones. And we all know diabetes is bad in terms of risk of heart attack and stroke, but it turns out lowering glucose doesn't really change that. So here are data from Accords, but there were a whole bunch of trials that looked at lower glycemic targets in patients who have diabetes that showed on the right side, you don't really change macrovascular outcomes unless you do it for like decades, and you do improve microvascular outcomes. And in fact, there's some data for PAD that you can reduce amputations with glycemic control. This is a sub-analysis of Accords, you can see here, but it's a really modest effect, and it takes a long time to show it. But like kidney disease, like retinopathy, there may be an effect of lowering glucose here, and this was one paper, but there's a lot of unmet need. So then enter the incretin era, and incretins are hormones that were identified in the 1930s. It took a long time to get sort of therapeutic GLP-1s because they don't last long in the circulation. You had to develop DPP-4 resistant peptides. There was a derivative of the Gila monster venom that allowed the development of exenatide and some of the early compounds. And then the longer acting formulations came, liraglutide, semaglutide. And I would say, for me at least, and maybe many in this room, 2016, like everything changed because the LEADER trial came out. And lo and behold, a GLP-1 receptor agonist, which this trial was done for safety, reduced MACE and mortality in a manner that was completely, we believe, distinct from any glycemic effect. So here you've got this drug that works. And then it was replicated in SUSTAIN-6 with semaglutide and REWIND with dulaglutide. So now GLP-1s improve cardiovascular outcomes, not quite sure how, looks distinct from glycemic control. People lose weight. Is it weight loss? Now, this LEADER was a New England Journal paper. It was a huge splash. I mean, it was this big deal. This analysis is actually more exciting to me. It was published in Diabetes Care. It was exploratory, post hoc, all that. But this looked at the effect of liraglutide and LEADER on diabetic foot ulceration and amputations, minor amputations, and you can see there was a clear benefit there. Again, this was exploratory post hoc, but it raised the hypothesis that you had a single drug that had macrovascular benefit, protecting heart attacks, but also microvascular benefits. And you've heard about what happened in the kidneys and other places. Then, this was STEP-HFpEF on the left. STEP-HFpEF asks a question of, do GLP-1 agonists, can they make you feel better and function better? And they did. Lo and behold, they made people walk better, function better. HFpEF, there probably is some microvascular component of it. And importantly, this was shown in patients with and without diabetes. So for the first time, we're out of diabetes at all. And we're just saying, does GLP-1 receptor agonist therapy improve outcomes? And then the big trial that Mike already talked about, SELECT, said, okay, let's forget about diabetes. Let's take people with a BMI of 27 or above with coronary disease, stroke, or PAD. The PAD group was small, but it was there. And there was clear benefit for MACE and mortality. And if you look at the curves in the upper left-hand corner and you think back to what we saw for glucose lowering, it's just a totally different effect, right? There's an immediate separation of the curves, immediate effect and benefit that's quite profound. So I put that on this slide, moving left to right in the blue, that now we have data in patients without diabetes for macrovascular outcomes, as well as for feeling or symptoms and function in heart failure. So that was the backdrop when STRIDE was designed. And STRIDE asked the question of, in patients with symptomatic PAD, could we make them feel better and function better and maybe survive longer if we treat them? And we chose a low dose of semaglutide. And I think that's really important because when you treat patients with PAD, there's a lot of weight loss. People worry about sarcopenia. This is the 1 milligram dose versus placebo. This is a functional outcome study. So who got in the trial? It was pretty inclusive. Patients with diabetes, early stage symptoms, so Fontan 2A, and abnormal hemodynamics. We only excluded people that had planned procedure or were medically unstable. And this is the baseline characteristics. You can see the ABIs on the left. Draw your attention to the middle two panels. This was supposed to be early stage PAD, and I think we're just getting these patients way too late. You can see how debilitated they were in terms of their ability to walk, and you could see that in how they rated their function on the far right. But we're probably diagnosing, if we think this is early stage PAD, we're missing people much earlier in the course of disease. All right, so maybe it's just about treating metabolic disease. Maybe it's just, they've got metabolic disease, let's treat it. Well, what about metformin? Metformin's a great drug. I mean, there's, a million papers out there that metformin cures cancer, all sorts of observational analyses. Mary McDermott did a really nicely controlled study here and showed no effect of metformin for function, for symptoms. There wasn't a single positive outcome in this trial. So it's not just as simple as saying we're treating the metabolic disease. In contrast, I'll show you for STRIDE, semaglutide had a clear effect by 6 months. It increased over time. Of course, this would be lifelong therapy, so these curves you would imagine would likely continue to diverge with a 40-meter delta in mean walking, which was met a pre-specified threshold for clinically meaningful improvement. So clear benefit. And we've talked a lot about what's driving it, and we looked, whether you're young or old, man or woman, or where you lived, your glycemic control, your BMI. We had people down to a BMI of 23. The effects were all the same. all the same. So none of those, had any effect on the benefit of semaglutide. This is data in women. In fact, they're rare that we have a powered subgroup in women in a trial with peripheral artery disease. And you can see on the left side of the slide, not only was there a statistically significant improvement in women, but when you look at the absolute change on the bars there, on the left bars, it was actually greater in women than in men. And so clear benefit in that population. We looked at patients who smoke. There was benefit. There looks like there's a little bit of a trend to greater benefit in those who had never smoked. There was no statistical heterogeneity. What's interesting is that smokers who took semaglutide did better, but they still never returned to the baseline of a non-smoker. And I think this really underscored that there's no one solution to this disease, that smoking cessation is critical, and the benefits should be additive. And then we talked a lot about diabetes. I know the type is small, but SGLT2 inhibitors, yes or no? Exactly the same effect. Glycemic control, BMI, diabetes duration, whether you're on insulin, all of the effects are independent. And I'm telling you this because we're going to get to mechanism in a moment, and it's really not a diabetes effect that we're talking about. Okay, so the benefits, maximal walking distance was the primary endpoint. You can see pain-free walking distance was significantly improved. Quality of life with two independent measures, the VascuQoL-6 and the SF-36 physical function domain, statistically significantly improved, and ankle brachial index. And this was really fascinating. So I showed you that the effects were present at 6 months. When you look at ABI over time, it's the same story. These are the baseline ABIs around 0.75, 0.76, and the benefit for ABI was present at 6 months and continued over time. It actually continued even after the drug was stopped. So 5 weeks after the last dose, the change in ABI was maintained. All right, so this metabolic therapy then, one of the questions was, is this just a Band-Aid? Are we just making people feel better? Or are we modifying the disease? And so one of the questions we asked was, what is happening to people in terms of their need for rescue therapy? So they have a rescue revascularization due to symptoms, major adverse limb event, or all-cause death. Now recognize this event rate's around 9%. And this is early stage PAD, so these are not low-risk patients. I think that's a misnomer. And we looked here in an exploratory fashion at what semaglutide did, and you can see there was about a halving in 1 year of the likelihood that they're going to progress to death, male mortality, death, male, or revascularization. Hypothesis generating, exploratory, but then coupled with the SOUL trial, which was presented at the same time, where formally adjudicated major adverse limb events were reported. So this is a stable population, large population of patients with diabetes. And this is, for most of them, the first presentation to a hospital was CLTI or ALI. And you can see a 30% reduction. The curves seem to diverge late. That's actually a phenomenon of small numbers. We have an updated analysis where you can see that the curves separate early, just like in SELECT. And so that really brings on the notion of, and we'll talk about this, there's a lot of focus on CLTI. It's a bad outcome. It's something to fear. But maybe we should be looking earlier at patients. We should be detecting, we should be screening, we should be asking, could this be the opportunity to prevent someone from getting CLTI? And this is an analysis. This is just CLTI from a meta-analysis of SOUL, FLOW, and STRIDE, showing that in these were patients who'd not had CLTI before, a 28% reduction in the first hospitalization for chronic limb-threatening ischemia. So we thought a disease modifier. So the next thing I'm going to show you, I think, is particularly exciting. So I started off talking about, we've looked at large vessel phenomenon, acute limb ischemia, major amputations, and that's here in this meta-analysis what was adjudicated. You can see 225 events, hospitalizations for ALI or CLI, and the effect in PAD around a 30% reduction. In fact, when you look at the investigator reported, you can see a clear benefit there, even if you hadn't adjudicated them. But the problem, what we brought up in the SFRM was the right side of this slide, was all of the stuff we don't really want to talk about with lipid lowering and with antithrombotics because they don't modify them. Diabetic foot ulcer, osteomyelitis, cellulitis. And we adjudicated these as well. And you can see the effect. There was almost a halving of the risk of microvascular complications. Now, we're going to talk about mechanism. You heard about CRP lowering, and it's sort of intuitive that if you lower CRP, you sort of tamp down the immune system, you're going to increase the risk of infections. You see the exact opposite here. And in some ways, it may be that you're sort of resetting the immune system. You're preventing the disordered sort of hyperinflammation related to cardiometabolic risk and allowing the immune system to do its job. And certainly you're treating microvascular disease. And so I think that is where we are currently for metabolic therapies. There's a lot going on here, and I think we do want to talk about mechanism. I will say that for SEMA, the effect for function, ABI, everything was within 6 months. This is TCPO2, so this is tissue perfusion with liraglutide. Same time frame, 6 months, you see microvascular perfusion improvement, significant improvement in patients here with more advanced PAD. And on the right side, very elegant biomarker analyses showing improvements in the inflammatory profile and angiogenic markers. So I'll end in just a moment here, but I'll say I think there's a lot of great stuff on the spectrum. Part of what intrigues me about what's been seen with semaglutide is the anti-inflammatory effects. I know Manesh and Josh are leading leader PAD with colchicine. I think that's going to be exciting. There's other agents there. There are other GLP-1 RAs, factor 11 inhibition, remnant cholesterol, LPA. There's a lot great on the horizon for PAD. This is Attain PAD, which is an ongoing study with orforglipron, oral. This is a population with and without diabetes. So for the first time, we'll have functional data in patients without diabetes, BMI down to 23. I think that'll be an exciting addition. There's a number of lipid-lowering trials. This is an oral PCSK9 for MACE and male, the large outcomes trial. There's also Coral Reef. This drug, Anne-Marie Navarre presented the LDL lowering data. This oral PCSK9 will be on the market probably soon, MACE plus male in its primary outcome. And via intervention, Manesh is chairing this along with Roxana, Skylar, and myself, and looking at MACE or male with inclisiran. And then finally, factor 11 inhibition. So Manesh is leading a big program. We're leading this together, Josh as well, for macrovascular outcomes. So my final point I'm going to make is that I love this meeting because it brings a lot of different people together. That's a real problem in vascular disease. I think for a long time, vascular medicine cardiologists, we've been talking about prescribing aspirin and statins to reduce heart attacks and leaving sort of the limb issues to our surgical colleagues and vice versa. And, now recognizing that, trials like Best CLI, if patients are going to die of their heart disease, we're missing an opportunity, and that there are medical therapies that now can change the progression of disease, make people feel and function better. And I think, we're now at the era, maybe this meeting is a nidus of bringing people together as a vascular team, because I think the medical therapy is getting too complicated for any one person to own. And when you think about titrating GLP-1s, LPA lowering, which antithrombotic, it's great news. It's got complicated. It's also bad news. It's become complicated. So thank you.
It's fantastic. Marc, we have about 10 minutes because of our rescheduling with the coffee break and such. Probably got to take a breath after that, huh? There's a lot going on, which is great in the field and gets us back to sort of some of the questions we had this morning. So let me start. Anybody with questions for Marc before I start peppering with some?
I'm ready.
In your opinion, who should own getting these medications prescribed to the patient? Is it a vascular specialist? Is it a primary care physician? Is it Amazon?
I think all of us own it. I think we're going to see people in different stages of disease. But I don't think we're ever going to really change the needle for PAD or change the trajectory unless we teach primary care to learn how to diagnose and detect it. I think I got an hour in medical school on vascular disease. And there's just too many patients that have it where they don't have access to a vascular surgeon or vascular specialist.
Yeah, it's a great question. Peter?
Hey, Marc. Great talk, as always. I always learn so much hearing the story from you. But, one of the things that we have trouble translating is how does the patient view it? How does the patient feel? What is their quality of life? And there's a lot more attention to that, as there should be going forward. And you just ran a quality of life study, essentially, just now. So you must have learned a tremendous amount. So what's the what's the one variable or the one? I mean, your outcome was mean walking distance. So is that what we should be looking to going forward rather than a 36 question test
Walking
that
impairment questionnaire.
people are, if they're feeling good that day and they had their coffee, it's one thing. And if they've had a bad experience because there was no parking, it's another thing. What should we be looking for as a thing that should be measured in every trial so that we'll be able to compare apples and oranges?
It's a great question. You know, it's interesting. It's particularly hard for prevention drugs like rivaroxaban, Voyager. You know, someone who's never experienced a major adverse limb event, they're just taking a drug twice a day and they get bruising or whatever. That's really hard to measure because, you know, people don't thank you for the event that they didn't know they didn't have, right? Because you prescribed the drug. In STRIDE, you know, we looked at an objective measure of function, but it's really hard to interpret that without getting quality of life, right? And so there are anchor measures you use to say, was this important to you? You know, was walking this more important to you? Because you could imagine a drug could make you walk an inch further, and that's totally meaningless. Here, it was highly statistically significant. The one caveat to quality of life, and you see this a little bit in SweetPad, is that people change their lives to adapt to their symptoms. And even in STRIDE, there were people that could hardly walk. And when you asked them if they felt limited, they said no. Because even if they could walk 50 meters, their life had been limited to 40. And so I think quality of life alone is problematic, right? Because we don't want people to change their lives. But in these sort of progressive diseases like aortic stenosis, if you modify how you live, you may not appreciate it. And so I think you need both, an objective measure and a quality of life measure.
Yeah, I think it's a great point. And if you look at, you know, people modify their lives so much, but this question you're asking, I think, is a central one. And it may not just be in the vascular field. It'll be like across a lot of the studies we're doing. What are there 2 or 3 things we can be getting from everyone to understand their quality of life and their functional status? I think it is critical. It's hard, though, because they're general measures and they're limb measures. It's hard to get both. We do see, if you think about non-limb, we see when you think about the TAVR study just out in the New England Journal, like asymptomatic people are still having significant benefit or reduction. So people are turning down their functional status the more they get limited by something. It is complicated.
The one interesting observation, we saw it in STRIDE, well-described phenomenon, is when you make people walk better, some of them develop angina.
Yeah. There's a whole different set of problems that opens up, but, you know, if the wheels are good, then the engine's got an issue.
My question's also about quality of life, actually. It's about the negative side effects associated with these drugs. And also, so not just the nausea and vomiting, but also like loss of pleasure of eating, which for certain cultures would be much harder than other cultures. You know, so as you know, I think for people who are at risk of death and major adverse events, it seems like it would be easier to counsel them about the need for these drugs. But as we start seeing improvements in prevention in patients who are at lower risk, how do you counsel patients to say, like, okay, this drug will help you, but you have to take it forever, and you'll lose your pleasure of eating all food, and you may vomit from time to time, and you'll probably be a little bit nauseous for the rest of your life, you know?
Well, yeah, that's a tough conversation. I think
I'm in.
People in the trial did pretty well, but I think you raise a really important point, and I think this is important. We have a lot of emphasis on weight loss and pushing to high doses of these drugs because of what's out in the community. This was 1 milligram of sema. There was no titration beyond that. People actually did really well. They didn't lose muscle mass. They didn't develop osteoporosis, osteopenia. And I think that's important. I think we can get the direct GLP-1 effects on the vasculature, anti-inflammatory effects at low doses, and we shouldn't put people into a position where they have the kinds of adverse effects that you described.
Yeah, I would just say that the interesting thing about GLP-1 for us right now is what Marc is describing is not the weight loss dose by any stretch. And what's interesting is the drugs were first tested, approved in 2005, 2006. And we sit here in 2026 for the first time starting to potentially unravel exactly how they might work, although they have these huge benefits. So it is striking that our biology and our science is catching up. And the only thing I'll say is 10% of people in the weight loss or cardiovascular trials stopped it, had nausea, vomiting. They weren't related to people stopping it all the time. It was some, and 10% didn't get a weight loss, or 5%. So it's interesting that I think it's going to be different for different people, and it's really hard to know. And in this dose, I would say for vascular patients, it'd be great to get their trade-offs, to say, what are you willing to tolerate to be able to walk farther? What's the patient voice on what would I tolerate to be able to do X, Y, or Z?
Mike's good.
Marc, always great. So many questions about Stride. I wanted to ask you about whether or not the starting hemodynamics had any impact on the benefit, and just getting back to the mechanism, because the curves separate pretty quickly.
Yeah.
And I have a hard time thinking about, for example, angiogenesis happening that fast.
No.
I'm going to guess Josh is going to maybe address this in some fashion, but what's your guess about mechanism, and then, and whether or not hemodynamic impairment, which is what we measure in the office all the time with tracking people, how's my ABI, how's my ankle pressure, is that, what other things should we be measuring, and what do you see as from Stride, what clues are there about the relationship between hemodynamics and the outcome?
Yeah, great question. I'll just say I don't think the improvement in ABI is a large vessel conduit phenomenon or angiogenic. Maybe long term, I think it's an anti-inflammatory and microvascular effect is what we're seeing. Is my guess, but we have to prove that. Now, it wasn't uniform. About 27% of the patients had a large change in ABI, 0.1 or greater, and why some people had more of a response than others, we don't know yet. We're looking into that. The baseline ABI was not a modifier of benefit. So if people started at 0.85 or they started at 0.6, they had all about the equivalent effect. But I think there's a lot more to learn about who the sort of hyper responders are.
Yeah, Mike, your question makes me think about the evolution that's happened in the coronary vasculature. We went from stenosis to wire down the vessel to microvascular to now AI-driven microvascular. I think probably what's happening in the skeletal tissue we still may not know, but I do think my guess is I bet it's inflammatory and microvascular. Other questions? Okay, thanks, Mark.